Hi everyone, I'm Carla Treloar from the Centre for Social Research and Health. Really excited to be at my first hackathon and so excited that it's about stigma. My job is to give you a bit of an intro to stigma and some tools, ideas to help you along the way with working out what we should be doing about it. So as an introduction, stigma leads to the social economic exclusion of individuals and groups based on real or perceived characteristics. Stigma is recognised as a key determinant of health and in particular of health inequities. Stigma undermines every step of the care cascade: prevention, testing, treatment, keeping people in care. And dealing with stigma should be a priority for every health service, regardless of whether an individual's experience of stigma happened sometime before they actually reached the door of today's health service. There's numbers of definitions of stigma, and this is the one we've worked with a lot, this 5-step process. That stigma occurs when people distinguish and label differences between individuals and groups. Those differences attract a negative attribute. Because of that negative attribute, people or groups are separated and distanced, us and them. And this culminates in a status loss or discrimination. But it is really important to understand that all of these steps happen within a context of power and control. There's something in it for the us group to separate, label, distinguish the them group. Stigma has the impacts of a number of different things that's important for us to consider. For a person, experiencing stigma can result in stress and shame, depression, isolation, and coping in ways that would be considered not the most helpful. It means that people might be less likely to disclose important things in the health setting because they're worried about how they would be treated if people knew about their HIV status, or that they're a man who has sex with men, or a person who injects drugs, or a sex worker. People might choose to avoid healthcare entirely because of the fear of being treated negatively. It also, once people get there, means that it might be difficult for people to remain adherent or retained in treatment, because having a bottle of pills or some other paraphernalia of health systems might result in unwanted disclosure in the home or at work or in other settings. And it can increase people's engagement in risk practices, particularly because of that sort of internalizing understanding of oneself as a result of messages of social stigma. I think it's really important for you guys going into this hackathon to think about a couple of different types of stigma or levels of stigma. I'm going to repeat this a couple of times because it's a really key, important message. Yes, people often think about stigma between people, the attitudes or language or mannerisms or behaviour that people use when they encounter someone from this stigmatised group. Yes, that's important, but it is not nearly the whole picture. It's really important to think about the policies and structures of health organisations, of the law, the way people in our stigmatised group are portrayed in media, and how those things are mutually reinforcing. And I've mentioned previously this notion of internalised stigma, where people take in those messages and it affects people's understandings of themselves in relation to self-belief and self-worth. So what does stigma matter to HIV? As I mentioned before, stigma affects every step of the care cascade. Delayed health service engagement, onward transmission concerns, and population level burden of disease are all important things to consider as why we should be tackling this subject, as well as the impact on people's quality of life and sense of self. So I've thrown up some information from the literature which reiterates these points, that when people experience HIV-related stigma, they're less likely to attend health services, less likely to adhere to treatment. It impacts disclosure and ways in which HIV-negative men engage with HIV-positive men. We've measured stigma using our stigma indicator. And again, I just wanted to briefly touch on this point. When we ask people living with HIV, have you experienced stigma or discrimination in the last 12 months? In our most recent survey in 2019, we had just over half of our sample saying yes, they had experienced any stigma in that recent 12-month period. When we ask, have health workers treated you negatively or differently to other people because of your HIV status, we have about a third of people saying, yes, this has happened. This is really important to think about and understand. The health system is where people go when they're feeling vulnerable, unwell, in need of assistance and care. To have that fear that they will be treated negatively, turned away, treated as lesser than, not the same as everyone else. This is a highly significant driver of ways in which issues that we could be improving healthcare for people living with HIV. So what works? The literature gives us a couple of ideas. I've listed 6 kind of categories of interventions, and they're mostly around that interpersonal aspect, giving people information, skills building, contact with affected groups. So there's other, number 3, for example, is aimed at people living with HIV. There is way less attention given to, particularly number 5, structural approaches, interventions that work above the individual at the organizational or the structural level to go, what could we be changing in the ways in which organizations run themselves, account for themselves, evaluate themselves. We know much less about those kinds of approaches. So what we know in terms of what works is limited by this gap in knowledge, because most interventions are aimed at that individual or interpersonal levels. So training is great, attitudinal change is great, but stigma isn't dismantled by education or attitude change only. Stigma perseveres in institutions, even those institutions like health systems which have an underlying ethos of quality. So this slide kind of sums up what I would really like you to take away from my little presentation today and take into your work tomorrow. To think about these 4 levels of stigma reduction, from the individual, how people understand themselves in relation to self-worth, self-belief, the interpersonal level, where we know how people can speak to each other, the kinds of languages they use, the mannerisms, their behaviours and actions, but also into these other 2, about the organisation, institution, how it runs, what's its policies and procedures, what's its quality framework? Can we do something there that really embeds stigma reduction as a key aspect of operations? And at the government, policy, laws, media, what can we be thinking about there that impacts the variety of things you could be thinking about over the next day? So good luck. I can't wait to see what you all come up with. I'll be part of the judging panel on Saturday evening. So go well, take in all the information you can. Can't wait to see what happens.